What's striking to me is that I think we have broad agreement that that what we've done for years isn't working and is way over medicalized the issue. I think the question is, what do we do next? So I think we're in this space, at least for all of us, of figuring out where do we go from here and how does this look. And I, at least now looking at the evidence, I don't think there is a one size, this is the right way to go. I think we're in this space where we're building out some evidence with these caveats.
So I'm going to start with the questions. This is a really good one. Does the adult literature inform us when we talk about weaning versus PRN doses?
It certainly has. I think the weaning that we've done, the weaning protocols, are all from adults, which is good because we know neonates are just little adults, so it works out great. That's where it comes from, because there aren't studies really looking at this in kids, really, much less neonates. So it was just adapted from the adult literature, and there is decent adult literature on it. And so the PRN stuff was just more like we just sort of were like, this seems to make sense. And one of the things, again, is sort of the box idea, is that just because we were doing something doesn't make it evidence. So most of the stuff we were doing, it wasn't really evidence-based. It was just, it wasn't a standard of care. We started to say it's really just the traditional model of care. And so if there's no basis for that, just because people have been doing it a lot, doesn't make it more evidence-based. So we said, this doesn't seem to make sense, and it's not accomplishing what we're trying to accomplish. What we're trying to do is have what is going to help us get to our goal, which is to have the baby be able to be like a baby. And it is not to give unnecessary doses of morphine, which is generally our goal, is not to give more things than we need to give, particularly, like, that's our big hospital medicine motto. So we're going to give it, we may give it it's PRN every 3 hours, so you can get it every 3 hours. So there are kids who have gotten 8 doses in a day, and that's fine. But most of the kids we found don't need that.
As a tack onto that, the other question was, what dose do you actually use for the PRN? This is left over. I've spent no time looking at this. It was, we were 0.05 per kilo, which was just what was in our original protocol. So I've spent 0 time looking at that. So maybe Stephen can answer that better.
Oh, as far as like, so this is just my NICU head, like the 0.05 per kilo is my non-intubated dose. 0.1 per kilo is my intubated dose. That's kind of what I think about.
Fair enough.
Yeah. There are multiple ways to treat in terms of, like, if you look at the literature, there are severity scores, severity dosing, there is standard dosing based upon weight. One of the things that's so confusing about this is there is no gold standard definition, and therefore all the studies are different, and there is no gold standard protocol. And so it makes all of this really confusing. And so I think some states have said, this is the protocol we're going to use. Many states, in terms of their quality improvement, have not done that. But I think Ohio had like a standard protocol that they were doing. And it's because there isn't great evidence for one way or the other. The evidence suggests keeping moms and babies together, breastfeeding when it's appropriate, and doing the same thing every time. I mean, that's really kind of the bulk of the evidence. That's what I was thinking.
So several questions in here about what you do when the parents either don't stay or don't stay overnight. How do you do volunteers? Mm-hmm. What happens? And what do you do if you are discharging to a family who has not stayed? What happens then?
Yeah. So again, as I mentioned, our goal with all this is to have this go well, both in the hospital and to set them up for as much success as possible at home. That's the goal of all this. So everyone who's going home has a slew of services that are set up, and at least one, if not, we have birth to 3 as an automatic service for our kids, not a referral, but a service in our state.
Intervention. Is that what
early intervention, yeah. And so we're one of the few states that automatically gives these kids the actual service, and everyone gets at least, we have 3 different parenting support organizations, and they are all, and we usually do a warm handoff with whichever one is in their area. Those are the keys. so we're thinking about those parts of it. If the family won't stay and the baby's going home to the family, we are still have the same concept of what the baby needs. And so that comes in a couple of parts. One is we think the best place for the baby is probably not, the worst place is the NICU, and the second worst place is probably on the floor where we have them. So how do we get them to some place that's going to be better, which is going to be with their family? And if the family's not there because they have 6 other kids and there's no other help, then those situations happen a lot. Most of the time we can find somebody else in the family to come and help, or we do it then. And so we throw everybody we can at them. We have our volunteer service is not it's not 24/7. I was telling somebody Boston Medical Center now has a 24/7 cuddlers. So they do that all night. And there are a lot of people this is a way that people can help with the opioid epidemic. They can actually do something. There is a lot of people who want to do that. So if you actually look to expand your cuddler population, you'll have a lot of people who want to help. We've had trouble doing that. Again, the bureaucracy of our institution. But we use medical student. Every one of these babies has a medical student attached to them or a PA student, and everyone gets the same speech of how they're going to make a difference in this baby because they're going to. And so we just say this baby has to feel loved and have that experience while in the hospital. And we have to know that the best place is going to be with whatever family is going to love them, whether it's their family or a foster family. The best treatment is to find somebody to love this baby full time. So we don't want to keep a baby because the family can't come or they're going to go into a foster family for 3 weeks on medication because the foster family isn't placed until we discharge them. So we want to try to do that faster. So we do push that a little bit, and we try to provide as much as we can and get them to that place that's going to love them, because we want this to go better. The sooner they're going to be bonded to whoever they're supposed to be bonded to, the better. And the longer we keep them away from that, the worse. So we sort of end up trying to get those kids moved along. Those are the ones where we actually do want to try to get our length of stay shorter because we want them with that person. Other than that, that's not a length of stay really isn't the goal for us.
I mean, the side effect of rooming in is engaging families early. So some families you might not suspect would be engaged are more engaged throughout the entire hospital stay. So it's sort of building out a system to set families up for success. I mean, the current system, and we have this in NICU families all the time, right? If there are NICU folks in here too, that where we take care of the infant for 6 months and it's like good luck, go home. It's a very similar thing. If you're engaging families, they're engaged in the care. Not everyone, but some people. It's the same with foster care placement. I think about 10% of our infants don't go home with mom. And so that's also an important partner. The other thing that he mentioned was, in early intervention, in Tennessee, it's TEIS, Early Intervention Services. And so we refer all infants to that. So as we've sort of gotten our length of stay down, our focus has really shifted to how can we better partner with our obstetric colleagues and how can we do a better job of handing off to going home. And so we've created like a checklist that the team has put out to make sure we have pediatrician follow-up if they've been exposed to hepatitis C follow-up, developmental follow-up. I'm going to forget any of this stuff. TEIS and something else. There were 5 things on it. I'm getting old. More caffeine perhaps. But I think that's one of the keys. One of the challenges we face in Tennessee, so we had a conversation last week. So we are diagnosing fewer kids with neonatal abstinence syndrome just by our care process change. And that changes things they're eligible for. In Tennessee, for early intervention, a qualifying diagnosis is neonatal abstinence syndrome. So if we have opioid exposed infants that we happen to not diagnose with neonatal abstinence syndrome, they're not going to get the same level of resources. And of course, the other complexity of this is child welfare. And so in some cases, there's one incentive to provide the diagnosis of NAS because they may get EI and other things like that. And then there's a big disincentive to not diagnose with neonatal abstinence syndrome for the concern of child welfare involvement in some cases. And we can talk about that too if that's of interest.
Yeah, and I think, and we've erred on putting the diagnosis of NAS on almost on the vast majority of our opioid exposed infants so that they will qualify for these services. And that's just how we look. We sort of treat every opioid exposed infant. They get treatment starting at birth. So that's kind of how we look at it. But really what we're looking at with it, we want this to go well long term. Like my biggest interest is that these kids do well as they get older. And so, we're all the sort of acute, or mostly the people who are doing this for the first few days. And even if it's a long length stay, it's still the first small amount of their lives. And so how much, we have no idea the impact of what we're doing or what these little things are, if any, on the long-term stuff. But that's the stuff I care about the most. And so I want to make sure the things that and we don't know, the follow-up studies are really difficult to do. There's going to be a lot more of them coming up. I'm sure you'll do them and they'll be great, please. But we just don't know that there's very little that's good. It's hard to keep track of these kids 10 and 15 years later. And so, but that's really what I'm most interested in, is how do we give these kids the best chance? And the evidence for it is we don't know yet. We do know that parenting support stuff works really well. And that there's evidence base behind that. So I want to make sure they all get that and they're feeling supported and ready to go. That to me is kind of the big picture thing.
Home nurse visitation was the other thing that I forgot, and that's on our checklist.
Okay. So a lot of questions about how you specifically trained your nursing pool, and then how large is your nursing pool, and do you have mother-baby nursing, and have you found that to be helpful?
Actually, so when I talked initially when we went to the nursery taking care of these kids, how it was sort of kicking and screaming. The finish of that story is that there was during the course of this, about a year went by and we noticed that we weren't getting babies down without their moms anymore. Because initially we were getting, it was the kid was there for a half a day and the score was 22, and the mom would come a day or two later. And then we weren't seeing that anymore, and we kind of went up to our nursery and said, "What's going on?" I said, "Well, we saw that you weren't that you weren't necessarily giving these kids medication right away, and we kind of saw how good it was to see the mom and baby together. So we stopped sending them down until the mom was ready to go, and that's really what has happened now. And usually the kids don't need, the timing works out. Even if you're going to give medication, usually it's not right away. It's usually a couple days in that once the methadone, and again, most of ours are methadone, which is pretty long acting, so it can be a little bit longer before you're going to need it. But that's the mother-baby nurses, and now they're doing about half of the care is in our nursery, and so they're really the ones doing the heavy lifting and the training, and those are all mother-baby nurses, and so they're really proud of the work they've done. I've published something about the nurses' experience with it, which reads differently from the other nursing experience studies. Like, they're really proud of the work they're doing and supporting the families and that kind of stuff, and how it feels really good and that kind of stuff. So we've definitely engaged them, and it was as I mentioned, slow going in the beginning, but they're really the kind of the key to the treatment now. I forget the rest of the question.
It was specific.
How to training, yeah. So the initial training, I mean, it's not like we just said like, hey, let's try this today. We kind of made fun of Finnegan for years and sort of eased our way into this. So the initial
That's
group,
where we are.
right? So that's the fun part.
Yeah.
And then we've actually switched units that these kids are managed on. So we've trained the new nursing staff on it, but people are kind of aware of what we're doing. We just kind of went over this sort of discussion. There's not a lot of training. We have a place we're an Epic place. We have a place where you can document. It's not really a score, but there's on the nursing sheet, there's an eat, sleep, console. So you can kind of check them off. And the idea is the training's pretty simple. It's, and we sort of arbitrarily pick numbers, and it turns out sleeping doesn't pop up that much. Usually if the kid isn't sleeping, they're also not consolable. So we've had very few times where we're doing anything based on sleep itself. But if you're inconsolable, the idea is if it's inconsolable, it's pretty easy. If you're having trouble consoling the baby, let's see, get the other providers. Let's figure out if we can do anything to fix it, get the mom. And if we can't, we'll give medication. Feeding, there's a little less urgency to it, and we look at it, and we're actually, some will give medication to, and some will actually put an NG tube in. If the kid's falling asleep, then we usually don't give that kid morphine right off the bat. And then we'll actually be more likely to do an NG tube for a couple of days, give them a bunch of calories until they aren't doing that. If they're more disorganized, usually we find we can sort of non-pharmacologic our way through that. And if we can't, then we'll give some morphine for those kids too. But that's it. So it's very little training. It's kind of natural care, and it's the care is mostly around the consoling. That respond, get the resident team and or whoever or the nursery person involved, and we'll see what we'll see if there's any non-pharmacological stuff we can increase. Try to feed the kid, make sure they're swaddled, make sure the lights are down, and if it doesn't work, we'll give a dose of morphine. And that's the part where we feel like that we were talking about we definitely went too far in the way of less morphine. And I find myself arguing with the family and the residents that like one dose is fine. And the idea is that it's not, it should be easier because it's not fraught with this whole weaning protocol anymore, that you can just give a dose and we'll see what happens and take it from there. And it doesn't necessarily extend length of stay. So it should be much freer. And so I'm hoping our numbers will go up. And Stephen mentioned they're more like 24%. Like
19%.
19%. Yeah. So that feels like closer to what I'd like ours to be, somewhere around that area.
And along that same line, do you have time constraints that you put on how long it takes to console, how long they should sleep, what their weight cutoff should be? Are there any safety parameters that you have around those things?
Yeah, though they're fairly arbitrary. We said you should be able to console the baby within 10 or 15 minutes, which just seemed like that's pretty normal at this age. Again, this is not a colic age. If you keep them long enough and you get into colic, then you're in trouble. then I don't know what to tell you. Feeding, we said they should be breastfeeding well or eating around an ounce of feed. And again, that one's less urgent. That's more we're monitoring and making sure the kid's eating well. We actually we stopped really looking at weight. And we're hoping we're starting to look at what the normal weight curves are for these kids. We know, 10% is the magic weight loss number. And what you do if you're a pediatrician and you get that is you say, okay, that's a little more than we normally see. Why is this happening? And for these kids, we know why it's happening. If you try to spend the day like this, you're going to use more calories. So these kids need a lot more in the way of calories for the time they're going through the more severe withdrawal, and then they don't as much. So as long as the kid's eating well, they will gain weight. So we don't worry about that as much. We will increase, if they're on formula, we will give them a higher calorie formula early, and often we'll do it right from the start. But we are looking at if they can eat well, and usually we think about an ounce is more than you should get in the first day or two, but they will need some more volume. So we're looking somewhere around there. If they're in that ballpark, then we're usually okay. But but it's not that strict with that, and we're not immediately if they have one feed that's not great, we're not immediately doing something. We're just monitoring that a little more closely. It's the consolability and the sleeping, but again, those usually end up going together that we're looking to react really quickly on.
Can you talk a little bit about eat, sleep, console with polysubstance use, and then what you do on like 24, 48 hours when it's more tobacco, SSRI, that kind of thing? How do you distinguish?
So there is so we don't is the answer. So there's nothing different to do with any of that stuff. So we don't. This is sort of regardless of exposure. It's not like if it's tobacco, we spin the baby like that or anything like that. It's all the same approaches. You will see there's like an eat, sleep, console tool, which if some of you have seen, which that tries to tell whether during this time it might, the nicotine stuff tends to be earlier, but we don't do anything differently. This is a pretty simple approach. It's just doing the intensive baby care stuff, and whatever they're exposed to, it doesn't really change that. When you get to medication, if they've had a heavy benzo exposure, we will consider treating with a benzo. That's where it comes different. But for the non-pharmacologic stuff, we've not found a lot of different. There are some people have tried to tailor things a little more directly towards the type of withdrawal signs but that's probably more than needs to be done. So it doesn't. The exposures really don't make much difference in our non-pharm stuff. I don't know if it does for you.
No.
Yeah.
But to your point about benzos, we just did some work looking at, it's a bunch of infants in Tennessee looking at a multitude of exposures, everything from, we reviewed like 1,000 charts throughout Tennessee. And we looked at, after accounting for marijuana, cocaine, you name the tobacco, all the exposures, gabapentin, the thing that was associated with more severe withdrawal requiring pharmacotherapy or leading to pharmacotherapy was benzo exposure. By far. So type of opioid and benzo exposure. Right.
And morphine is not a treatment for benzo withdrawal. So that's important. Like that's sort of what you'll see, we keep going up on the morphine for this kid with benzo withdrawal. It's not the treatment for it. So if you look at the AP guidelines, it's a like medication. So it doesn't say much more than that, but we have tended to, we've always had a lot more respect for the benzo withdrawal. So there's polypharmacy, and then there's lots of polypharmacy stuff, which we don't see much difference, but we are always looking for the benzo one. And if they're, and we haven't done it in a while, but we would use a little, there was no guidance for this, but we were working with our pharmacy and using small doses of Ativan for those kids, because that is not the treatment for benzo withdrawal. And that's why you notice they need more and more, because that's not what treats it.
So I think for us, so we are tending to use fewer benzodiazepines, period, and newborns. This is true for like intubation. It's true for even just treatment, because it's associated with some developmental issues later on. It's associated. So we tend to not do that. We also tend to not use phenobarbital. Same fears for seizures. Primarily, we're using Keppra, not phenobarbital. There are some studies to show in febrile seizures, developmental delay issues in kids. So what we tend to do is morphine first, and then clonidine as a second agent, because of those issues. And the literature on NAS and benzo use is kind of, Cochrane says not to use. That's what we tend to do. And usually I can count on the times on my hand that I've seen isolated benzo withdrawal. It does happen. It's usually an opioid plus something else.
So along those same lines, which great questions, long-term implications of giving more or less medication.
Yeah.
And then another great question, if they're using methadone currently and decide to move to PRN dosing, would it make more sense to go to morphine for PRN dosing? So 2 parts to that question. What do we know about long-term? And then do we need long-acting for long-acting?
We don't know is the long-term stuff. So, and my answer to the long-term, if they do long-term studies and they find that keeping the babies in the hospital for 30 days and doing long morphine tapers is better long-term, that's what we'll start doing. But I think that's probably unlikely, but that's what we would do. And then the methadone PRN, Boston Medical Center, I think, just published something where they were doing methadone PRN, so you can certainly do it that way.
So in terms of, I'm wearing the mic. I feel like I'm hogging the mic.
I'm giving it to you every time, and you have a mic.
So none of the studies really looked at what the effect of what we're doing postnatally does. So they all are kind of, and it's one of the issues with the literature too. So the literature on long-term outcomes is really focused on not the things that I think really could affect. So what alcohol co-use is probably the reason for developmental issues long-term. What else is happening? What about toxic stress? What about all those things we think are mattering aren't really accounting for that? So I think we need more studies to understand what does long-term treatment mean, and I think the substance matters too. So we looked at something. So one of the things we don't do either is discharge home on medications. Also here in Tennessee, we did some work looking at treating as an outpatient. So if infants started with medication in the hospital, one cohort stayed in, were treated in the hospital, the other went home on a medication. Infants that went home on a medication were on that medication 3 times longer than the infants treated in the hospital. So it did decrease length of stay, but total length of treatment was longer. The longest tail of that was 200 days for one infant. And imagine that, like in adults don't go through 200 days of withdrawal. 89% of those infants were on phenobarbital. And that worries me, and it worries me for development long term. The other question of like PRN dosing, we have no evidence for any of this in terms of really rigorous control, and they're really tough to do, and that's hard. The literature, if you look at it overall in terms of length of stay, which again I'm not sure suggests that methadone and buprenorphine decrease length of stay. But here's the question: what's the construct around that? What's the protocol that led to that? I sort of overall am a believer that it's more about the care process, the family engagement, those pieces that make the biggest difference. If you're looking at the literature the way it stands now, it suggests a long-acting opioid decreased length of stay.
Yeah, the issue, there's issues with the literature. So the stuff where there is, where I feel like the literature is strongest is to say that the supporting the families stuff, the bonding and supporting the families. So separating babies from their moms, we have good evidence that's a bad idea. I don't know that anyone needed a lot of evidence for that, but that's a bad idea. And then supporting them going forward is really important. The other stuff we don't know. Some of the literature with the treatment stuff, I feel like the issues I have, there is a lot of literature, but if you have not done I don't know how valuable it is to look at studies that have not really done a lot of the first line treatment and to say, so if you look at the study in Maine where they said, oh, methadone works better, and they're not doing non-pharmacologic care, I don't know that it's meaningful to me. I don't know what that information is not, that is to me, a study that adds nothing, because I want to see the studies where you are actually doing intensive non-pharmacologic care and then looking at stuff. And there really are very, very few of those. And the literature in terms of how you wean, and there's no evidence for the PRN stuff. Like, we have presented what we've done, and so have other places, but there also isn't evidence for the way that everyone else is doing it either. It's just what has been done. There's no study comparing these different weaning approaches. There's some of the outpatient stuff, but there's nobody saying like, oh, what's 1 day versus 2 days, or doing by this dose or that dose. It's just what's been done. And so I look at that as freeing and saying, no, we shouldn't, well, there isn't evidence to do PRN, therefore we should keep doing what we've been doing, even though there's no evidence for that, but it seems to be what everyone else is doing. It says, no, we have to look, okay, there isn't evidence for everything, we have to decide what to do, and do we want to do what makes sense and gets us towards our goal, or do we want to just do what we've always done? And I would say the evidence for what we've always done is that it's really, really long lengths of stay and lots of medications. And we also don't know the safety, the safety of morphine in babies is also a question. We don't, now it may be different in babies who are withdrawing. It's almost like, and the same thing with the benzo idea, like I almost look at it, if you're withdrawing, it's almost like you have you're deficient in those things, and so it may be a little bit different than just giving them. But I think it's a trap to say, well, there isn't evidence for these other ways, we'll just keep doing how we've been doing it, even though there's not evidence for that either. And I would say the evidence for what we've been doing is that's not that good in general. Not like the little parts of it, but the overall traditional Finnegan model, keeping kids forever, I think the evidence suggests it's a bad way to do it.
I tend to be just a bit more cautious.
Yes.
And I think the lack of evidence isn't necessarily an argument for doing something different, because you also don't know the evidence for that. And so I tend to be a little bit more cautious in terms of wondering about the potential implications. So, in medicine we have in neonatology, look at the story of steroids in terms of us doing something different and then leading to. So I have a little bit more caution, and maybe that's the neonatologist in me. I don't know. But I tend to be slightly more cautious. The other thing that I would just challenge us is when we're thinking about the literature is the difference between effectiveness and efficacy. So randomized controlled trials, if they're done well, they are targeted to look at efficacy. And so what that means is this is the protocol, and it is a study protocol designed to look at methadone versus morphine, and those kids should look the same except for methadone and morphine. And what that means is that it may be a very specific population that they're looking at. That's efficacy. So they can look at it's like the phenobarbital study. So looking at, okay, in this population, phenobarbital resulted in half the length of stay. So that's efficacy when we look at a very specific population. Effectiveness is when we do it in our populations, as we kind of get out what's more effective. And that's kind of what we've been talking about. And it's important for us to think through as we apply some of the studies that are out there, the difference, what population they were looking at, how we may incrementally apply these things. I hope that makes sense.
Yeah, the issue I have with the randomized control trials is you're supposed to randomize after you control for the things that you can think are going to be important, right? You don't just totally randomize everybody. And they have not even looked at the first line treatment.
The right question is, in my unit, the clinical question is not necessarily what's working better, morphine or methadone, it's what care process works better. And the literature is focused on which medicine as opposed to what care process. That's what's skewed.
Or even looking at which medicine while you're delivering good non-pharmacologic care. We've never had that one.
Sure.
Yeah.
But if you could infer from a good randomized controlled trial looking at morphine versus methadone, even if they had bad non-pharm care, if you had good non-pharm care, that independent effect should still be there.
When we're talking about moms who are engaged in treatment and not engaged in treatment at the time that they come in to deliver, can you talk a little bit about what your process is prenatally, what type of education you provide, how do you counsel about breastfeeding, and then do your statistics differ for a mom who's been engaged in prenatal care and has had this education versus the ones who don't?
So I don't have a great answer for that. So we do a really good job in our state of getting people into treatment programs, at least at some point. We have very few people who make it all the way to the end without anything. There's a lot of people who got in the last month or so, which we don't have any way of separating that out. the prenatal program, we actually, not everybody goes. It's really the people within the private groups are not all going with the prenatal preparation as much as our sort of Yale group. So we have not actually separated those out. We don't have a ton of variation in, the metrics we're looking for are not really designed to look at that. We can still, for most of those, we can still get them to stay, and we do the prenatal part postnatally, and we're still able to get most folks to stay, and we don't see a big change in the stuff that we measure, which is the hospital stuff we measure, which is length of stay and all that kind of stuff. So it hasn't had a giant impact on us because we kind of are able to fold those other folks in. And the percentage of folks who make it all the way to the end without getting put into a program is too small for us to really draw any conclusions.
What do you think, Ann?
We do have a smattering of moms who come in who have not been engaged in care, and it definitely is harder. They're not prepared. And so it has definitely made a difference from what we see.
I think one of the other things, this is where at least our research group has like shifted focus a little bit, is looking prenatally and then looking postnatally, because I think the systems that surround our families are so complex and oftentimes not set up to make families successful. So we're doing some work right now looking at barriers to treatment for pregnant women, and no shocker. So we should have data finalized on this in the next 6 months or so. Pregnant women have a harder time getting into treatment. All things equal, pregnant women have a harder time getting into treatment than non-pregnant women, period. And so we're going to have a lot more to say about that in the next 6 months to a year in terms of lots of data. But I think that's the context, particularly where a lot of our families are. So the opioid crisis disproportionately in our states and many states like it has affected rural communities where it is very difficult to get into treatment. And that's part of the complexity of where we are. So what matters more, our care delivery or getting moms into treatment, and then that postnatal stuff in terms of getting connected. I think that's probably where, at least in my mind, society stepping back, that's where I think a lot of our focus should be.
Okay. Can you talk a little bit about how you address the nursing care model to decrease stigma? And then how do you handle disagreements between the family and the nurse about when treatment needs to start? And how do you handle that overnight if there's not a provider in-house?
You do that first.
Sure,
Easy
that's
question.
easy.
Such great questions.
I feel like I've been going for. I gotta see that one again.
This one was stigma.
Okay.
So, and then I
So the
tacked
first one was
on.
about, because I was hoping Matt would just take that.
I can do the stigma. I'll do stigma.
Oh, okay, sure, take stigma.
Yeah, that sounds
All
easy.
right,
So we did that by accident and didn't realize we were doing it. We were a very small floor with 20 nurses probably, and we were doing this over years. And it wasn't until I went somewhere else. Two things happened: going somewhere else and seeing, oh, this is what it used to be like here, and then having a traveler nurse come in and seeing that calling Child Protective Services because the mom looked sleepy, and being like, oh no, this has changed for us here. And I think it was just there were a couple parts to it. One was understanding that it doesn't help anything when you're sort of angry at the family, that it's not good for anybody. It's not why anybody went into the field was to be angry at people. It was to help people. And who needs more help that we see than these folks, this baby and this mom? We can have a real impact on it. It was seeing that, and also seeing the difference, these nurses who had seen what it was like when we didn't support the families, and then what it was like when they did, and also what it meant for their workload. This was obviously, you couldn't have a nurse have two NAS. You could have NAS baby and a smaller workload because you had so much to do. Now, these are among the easier babies to care for on the floor because the mom does everything. Family's doing everything. You're just there trying to support them. So the self-interest of it, like, oh my God, if I can just sort of show them and support them, then they're doing everything. And I'm just if they're breastfeeding, I don't have much to do here. These babies are like, there's no hospital stuff to do for these babies. So that became really self-fulfilling. If we can do this, and it just felt better when they felt like, no, these are my people. I'm going to support them, and it made people feel better about their jobs. They didn't want to, and this is what you see in the NICU literature is these NICU nurses who are taking care of these whatever those pretend very tiny babies are, and putting them on ECMO, and that the hardest ones for them to care for were these full-size NAS babies. And so it was just changing that idea that these were people who needed our help, and having that turnaround and seeing it wasn't anything on purpose in the beginning. It was just everyone seeing how much better it was. Having our nursery see that, wow, when the mom and baby are together, it's a mom and a baby. And that we've been thinking about this as this is an addict, and this is a junkie, and this is the baby who's going through all this stuff, and actually seeing, no, it's a mom and a baby. So that happened on its own. It's pretty powerful to see it. And we've seen that other places we've gone, have gone through this, have seen that it's a pretty easy transition, actually.
I think the answer to that question is kind of related. So, I think, and we can think about our own judgment. So like what I'm going to say is, I'm going to say something about stigma that sounds really high and mighty. But when I'm in the unit and there's a mom who's, been using meth and she delivers 28-week twins, my own internal judgment happens, right? I mean, that's just my own we're all human beings. We do know that like stepping back and understanding what's going on with families does inform things. We know the science of addiction. We know these things, right? But I think it really has to do with conversations and hearing people's stories, listening to families that sort of begins to fight that stigma. So I'm from a small town in West Virginia, and in that town, 5% of babies were diagnosed with neonatal abstinence syndrome. 5%. So you can imagine and maybe you guys are from communities that are similar. I mean, this is everywhere. Like the opioid crisis kills 5 Tennesseans a day. I mean, this is happening everywhere. And stigma gets in the way of people getting help, period. And there's likely no greater stigmatized population when it comes to the opioid crisis than pregnant women. Because the common response is, how could you do this to your baby? And what we know from the literature is 3/4 of these women have physical abuse in their background, half sexual abuse. That's just the truth. And it's not like somebody got pregnant and said, I think I'm going to start using opioids now. There's a long narrative that's there. And so for me personally, it's trying to understand that and communicate. And I think when it comes to conflict, it's the same. It's trying to build a relationship early. I mean, we're trying our best to have prenatal consults in our clinic for women with opioid use disorder. So how can we have a relationship as opposed to just walking in and saying, I need to start some opioids on your baby today? That you have a long history of mistrust of the healthcare system and systems in general, and you can see why. People have been failed by systems before. So how can you build trust over the long haul? I think that's really what begins to help with some of those conflicts.
And do you have a specific situation where the parents and the nursing staff have not agreed about when a baby needed to be treated or not? Or do you usually huddle and everybody agrees?
Yeah, I think we I can't think of, it's gone in different ways. I think it used to be that we felt like we were first doing this, that maybe some of the moms were nervous that we weren't giving medication. And now I'm finding it tends to be me trying to encourage people that it's okay to do a dose of it, both the nursing staff, the residents, and the mom. So it's really a group, we do it all as a group decision, and we sort of talk through here's the situation, here's how the game plan works. If this is all going well, then we won't use any medication, and if the baby's having a little more difficulty, then whatever we're doing, we'll be doing 90% of the job, and then the medication we'll give a dose here and there that will do the additional 10% to make sure that your baby's comfortable. And we really haven't had, kind of presenting it that way, we haven't really had much in the way of disagreements other than just people feeling a little that it's okay to give the medication.
I'm curious what you think too, Hannah, but I think just in general, the conflicts that I recall mostly are with parents, not with the team. In part because you kind of meet, talk. I think part of it is, at least for physicians, is to, take your ego aside and understand that we're a team. And the team includes everyone who's on the team, and that includes the parents. So if you're engaging people in a conversation of this is what we see, what do you think about this? I mean, oftentimes those conflicts can be mitigated pretty quickly if you just understand that you are part of a team and not the team. As one person, and I think engaging families is important too. I mean, the times where I've had conflicts with families has been primarily the mom who's been told, who's been in treatment that's completely separate from prenatal care, and is told, we're going to give you Subutex, and then your baby won't have withdrawal. Then the baby has withdrawal, and then you walk in and say, oh, look, we've got to treat your baby with a med.
If treatment is delayed, do you sometimes see an increase in dosing? Do you have any information about that? Do you feel like if you delay treatment and the baby escalates, that they actually require a higher level of dosing with morphine? Is there any evidence for higher scores to require higher dosing?
So if you do nothing with withdrawal, it is a self-limited process. So it will get worse, and it will get better, somewhere along the way. So that has certainly not been our experience. The problem that I think that we run into is, I think we should there's times where we should give a dose here and we don't, and then by the time I can get everyone to agree, the baby's here and doesn't need it anymore. And so that has not been our experience at all with the delay, because that's just the natural. It may be a longer arc with different kids. The arc can be like this and it can be like that, but it's going to be an arc. It doesn't last forever. So we have not found that. I don't know what your experience has been.
Well, we tend to protocolize it still. So, I mean, I don't know that there is evidence around severity-based dosing, or at least processes. I think the fundamental question is, when you have an infant who is in that process, one of our goals is if we had a bunch of adults in the room and said, hey, we're going to stop your opioid, you're going to go through withdrawal, and we're just going to watch you. And then we may give you a dose of morphine if you reach a certain threshold. I think part of our job is figuring out, and this is where this tension is that at what point in that curve do we intervene, and how do we intervene? Because we're trying to reduce the clinical signs of withdrawal to make the baby comfortable, but not too comfortable, right? That's really where we are.
Yeah.
Like, what can we tolerate in terms of normal baby behavior versus withdrawal? And so I think that's the tension of, there is not one, this is the right answer. I think it's us figuring out as a field, which is hard because there isn't a lot of evidence for many of the things we're talking about. Where do we pick that point? What is that threshold? We think the 2/8 is probably silly, but what is it, and how do we operationalize that? That's really a challenge right now.
Several questions on staffing and how the unit staffed. You answered the question about mother-baby staffing earlier, but when you have a baby who is needing eat, sleep, console sort of care, and you don't have a caregiver there, how do you handle that from a staffing perspective?
So our staffing ratios, again, I would say that the eat, sleep, console is what we do with all of our babies in the nursery. Like, that's what we're making sure they're all consolable and they're all eating okay and they're all sleeping okay. Like, that's right. Doesn't that sound like stuff you pay attention to on babies? So we do that on everybody. We do not, our ratios are no different. So it's, whatever the nurse, I forget what they are, but they're no different in the nursery whether you have babies with NAS or not, or on the floor. And so, but we do, if there is a night, in the nursery, it's not a problem. The mom's there for us by definition, because once the mom leaves, they leave together to go to the floor. So when the mom's discharged, they both are moved to the floor. So it's only on the inpatient unit, and then it's a sort of team effort at that point. If there's nobody there and the baby needs to be held, then the staff as a team figures it out, but the ratios are no different.
Okay. What strategies did you use to implement rooming in on the floor? And if you're looking at, some of our hospitals are adult only, they're not children's hospitals. So they have a birthing unit, but they don't have a children's hospital. So what types of arguments could you make, or would you present to the administrative team to convince them to have a rooming in model?
So, when we looked at our data in our hospital, when we first started, we allowed rooming in on our inpatient unit. The parents were allowed. We certainly weren't encouraging them, and we were maybe even discouraging them a little bit. And then when we saw, wow, when they stay, it seems to, and it was along with the other non-pharmacologic thing, but that was the big one, that this was really important, and it had this great, really powerful effect that we should encourage it. As we thought about it more as the medication kind of model, if you have somebody with asthma, you don't encourage the pharmacist to come and bring the albuterol. Like, that's the medication, so they have to come do it. So we sort of changed from encouraging to sort of demanding it. Like, you are the treatment for your baby, so you have to be here. So we don't say, like, it would be great if you could stay. It's, you're the treatment for your baby. You have to be here. If you can't be here, who can be here? So we really are pretty forceful that we're supportive, because we're saying you're the one who's going to get your baby better. And if you remember the what the moms are feeling. One of them is guilt, and this is one of the treatments for that. Is yes, what you were taking is your baby's going through this because of that, but you're the one who's going to fix it. And so it's very much thinking the medication model. You have to be here, or somebody does. What can we do to help? And so we bent some of the rules about, if they have, I have 2 kids at home and you don't allow these other kids in during this time of the year. Well, we bend the rules on that one. What I would say is it is the treatment, and this is where the box comes in, because we've had a lot of places where say like, oh no, we can't do rooming in. We have this NICU and it's not set up for rooming. We can't do rooming in. And so the other way to look at it is no, you have to do rooming in. Figure it out now. Like that is make that the must. We must have a situation where the mom and baby can stay together. Now figure it out. And we've done that, and that's what we've done around our state. Is people have had different solutions to that, where they've kind of built little areas around it where the mom can stay, or they have like one treatment room and they end up using that. But that's the idea, is to just change how you look at it, and not saying, oh no, we can't do these things here. It's no, this is the first principle is the mom and baby must be together. Figure it out.
I think the argument, thinking about how do you engage your C-suite, right? I think that's really the question. Like the folks who, and I think a length of stay argument is a pretty effective one in terms of, rooming in really does seem to decrease length of stay. So we can figure out a way to pull this off. It's going to drive and particularly in a setting where we are increasingly paid bundles, the hospital is incentivized to decrease length of stay, because if they decrease length of stay, they may increase revenue for the hospital potentially, and that's a really, it's not quite that clear, but that is one way to do it in terms of getting buy-in. I think part of it is targeting your message to whomever you're talking to, because different people are motivated by different things.
Yeah, I did sneak in one graph where the cost was down by 75%. Our C-suite could not like this project any more than they do. This has been, our Medicaid reimbursement is terrible, and so they think this is, like, we can show how many millions of dollars a year we save by not doing the old way we were doing it. So they absolutely love it. The issue with the financial argument, it can be in some of those community hospitals where it's 50%, and you're trying to convince whoever's running the NICU there that we suddenly your population is going to be, your census is going to go way down, and that's a tougher argument.
There can be a conflict between the physicians and the hospitals because they're paid differently.
Yep.
Bundled care for hospitals and daily billing for physicians, and there can be just flat out conflicts with that. And so that's why you got to get in a room and kind of begin to hash things out a bit and see what you can do, and even if it includes some modification of what you do.
Mm-hmm.
So the next question, do all of your opioid exposed infants still stay 5 days? And then if you do a PRN dose, how long do you watch the baby prior to discharge?
So our discharge criteria are, we want you to be over the hump of your withdrawal. For the long-acting ones, it tends to be somewhere in the 4 to 6 days. Or if you have a short-acting one, it's sooner than that. The main discharge criteria is that the family's ready. And so that tends to be on average, around 5 days. Sometimes it's a little bit longer. Sometimes it's short. If this is their third one, they're like, when can we go? And we can go, we'll do that. We can do that at 4 days. We'd rather not have the withdrawal signs really the baby getting a lot worse when they're going home. Although people have suggested that there may be some populations where you have a confident mom who's handled this who can do that. We have not done that, although I've seen stuff on the listserv saying, why don't we just discharge them right away and do that, and maybe there's some that would be fine. But generally it's somewhere between, occasionally if we have somebody who's on oxycodone, usually the withdrawal will be very, very quick, and that could be like 3 days. We've had maybe 3 days, but usually it's somewhere around 4 days to 6 days. The guidelines will say 4 to 7 days, which are totally made up, but it's kind of where we've landed. But it can be 8 days if the family's not ready. So that's the main criteria, is the family feeling like, yeah, we got this. So that's what we're mostly looking for.
I mean, that's what we do too. We are potentially working on a clinical risk prediction tool that we've developed. So the question is, for some kids who have very low risk of opioid withdrawal, like short-acting opioids, all the other, or if there aren't multiple co-exposures, could those kids be discharged home the time mom is? So that's something we're sort of actively thinking about, and how we would potentially operationalize that and test that, because we do feel like that we probably, if we were thinking about one place that we sort of overdo it, it's probably in those low risk observations. But the question is, how do we effectively identify who is low risk?
So several questions that just how do you know that the baby is feeding effectively if you're not the one doing the feed? How do you know that the baby is sleeping if you're not the one in the room? So basically, how do you accomplish that type of observation? And this particular question particularly points out that the parent is not available. So when you're trying to do on-demand feedings and you don't have a family in the room watching for those feeding cues, what are your workarounds for that?
So it doesn't go as well when the family's not there, to be clear. It's not as good. During the day, we will have a volunteer and it's sort of the same volunteers, so they know, they get the same spiel, you are the treatment for this baby, blah, 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 and they're the ones running it. Off hours, it's a little bit harder. The nursing staff and the patient care associates they're very attuned to this. It doesn't work as well, and sometimes we can be a little bit later than we'd want to be to it. And so the difference between having the mom there is the idea of, once these babies get going, you've all seen it snowballs. And if you're a nurse and you have 3 other kids and you're giving meds to that one, and something happens, you got to give a breathing treatment there, something's going on there, you can't get there for 20 minutes. And by then, the kid who was a little bit doing this is all, I don't need to tell you guys, is a disaster. And so, and also the feeding is, and usually the first thing we say is try to feed. It was 20 minutes ago, great, try again. The person who can do that is somebody at the bedside. So if you're not gonna have somebody at the bedside or with the kid, those are gonna be delayed. It's not gonna work as well. And that's why this baby needs to be with somebody who's going to love them full time. And so if that means a foster family, how do we get them to the foster family sooner? And so it's a balance of making sure you're not sending these kids home too soon, but also getting them the care they need. The care they need is not from us. It shouldn't be delivered by us. So you need somebody whose only job at that time is to care for that baby. And that is not a nurse, because the nurse, unless you have one-to-one nursing for these kids, which I'm pretty sure you don't, that's not going to be you. So we always think, like, if we can't get anyone there, how do we extend our cuddlers? How do we have somebody who can be there as our family members? And if there can't be, we've had ones where the mom's like, I don't want to see the baby, I'm dropping him off, adoption. We got to get them. We're fighting with DCF. Give us a foster family. We want to get the foster family in there, somebody to be there full time. It doesn't go as well, but we balance that. How do we think if the kid's not doing as well, but when somebody is holding the kid does great. That's a kid we want to get to a family as soon as possible and not go through that. So it's a little bit dicier, but.
Do you have any complementary therapies such as music, essential oils, massage, or any of those things used on your unit?
Metallica?
Yes, light heavy metal. We do music. Our child life's involved with every one of these kids. We are starting to do the massage with one person. I love the massage. I think it's so cool. So we have one person who does that a little bit. I think I've at St. Louis they do that a lot. It's pretty cool. We have not done. I've seen the stuff on oils. We have not done that. But yeah, the music and child life and a little massage. Does anyone do the massage around here?
Aaron?
It's so cool when everything kind of loosens out. I find that awesome. So we don't have the trying to get somebody else who wants to do it. But
So Aaron's done some infant massage training and.
So what I've done, the child life specialist with here at Vanderbilt, is been in training to instruct mothers to do the infant massage.
Yeah.
And so that's one of our efforts to create that connection between mom and baby too, and help mom feel more successful that she really is the person that is helping her baby the most.
perfect.
I should say for our folks, like, you saw the graph, like the NICU 2% of the time. Like I don't do anything but talk. So talk to like Betty and Aaron and folks like that from our team for some of the questions about this, and the rest of Lauren, Hannah, and the folks like that when it comes to these things, because they're the ones who are doing it.
So I was trained through the Loving Touch Foundation. There are other infant massage training where you are training to teach infant massage to the parents. And so Loving Touch is just the one that we were able to go with. You can go to their website. They have trainings across the country periodically throughout the year. I feel like I'm like top
You're doing great.
Yeah, come on down,
Yeah.
Anna.
So there's another question about how you train primary care providers and how you got buy-in from like your community providers or community pediatricians, et cetera.
Yeah, to be clear, I don't do anything either. Yeah, I give like one rah-rah speech and that's kind of it. And like, that's
That's true for most
yeah,
doctors.
that's classic for the
That's okay,
hospitals. I
that's
don't
true.
do anything.
We aren't
Sorry.
actually doing any
No.
of this work, so.
So this was not, we did not really have to do the buy-in from the providers. We are a interesting model where we are mostly hospitalists, but we have a lot of community pediatricians who come in as well and they see their patients. From the beginning, the only exception was that they put all of the babies with NAS on my service. So very few of them actually took care of these babies. And it ended up being whatever changes we made kind of rolled from the residents to the attendings. And they just said, yeah, just follow whatever protocol you guys are doing. So they were educated on it, but they're not really, they're doing even less than me on it. So that's not something we had to do, but it is the idea of kind of giving these kinds of explanations. This is what we're doing and why, and here's what your role is. And we've done that a little bit and more one-on-ones for us, but it's not as big a problem for us.
Next question is about safe sleep. When we have sleepier moms, how do you address that? What kind of safety parameters do you have around that?
Yeah, this is interesting. I think we've this is when I think of the nurse who came in and called Child Protective Services because the mom was sleepy. So particularly with methadone, the dose during pregnancy is quite a bit higher than it is during non-pregnancy time. And so basically, once the baby's delivered, these moms are on doses that are too high. And usually within a week or so, where we are a week, they bring them down. So they're on an overdose for a week, which will make you sleepy. It is not a character flaw. It is what, if any of us take a lot of methadone, we'll get sleepy. And so we have that conversation. You are going to be sleepier until your dose comes down. And you know what, I don't know if anyone's had a baby. Sometimes it's tiring. Does anyone remember that? Yes. So that's without the methadone.
I didn't have a baby.
I didn't
it wasn't
either,
a
and I
baby.
was really tired. So we're pretty upfront about those things with the moms and saying, look, if one of the concerns is you're going to be holding the baby, it's going to be great, you're going to get sleepy, which it's definitely going to happen. And so we're checking on that. We're looking for that. Where we make sure whenever you're sitting that the call bell is easy. If you feel sleepy, come get it. And the idea is that the staff understands, like, yeah, these are going to be sleepier people. And so how do we help with that? We have not had a problem with a baby being dropped. That's the biggest concern. I want to pad the floors personally, but no one seems to be good for that one. But this is going to be a problem that will, once the dose goes down, will be much less of a problem. But in that time in the hospital, it is a concern. So we're just talking about it all the time, and awareness has been our major thing.
Modeling safe sleep is really important. We know that the literature, again, like we've said, for everything is kind of murky, but these infants appear to be at increased risk for sleep-related deaths later. So making sure you model safe sleep is important. Swaddling is the one that always is the issue that we sort of work through. Like, when do we sort of like begin to adapt from going like an intense swaddle to sort of weaning the non-pharm care for a little bit? Because oftentimes I've heard this from in the community. If they're discharged, they're swaddled, and then you go to a daycare setting, the daycare can't swaddle them because of safe sleep, and so there becomes this question of what do we do? So I think beginning to talk about safe sleep is really important. Sitting on and Anna too, the fetal infant mortality review, there's so many sleep-related deaths are just related to not having a place to sleep. So having that conversation, making sure that you talk about, does your infant have their own place to sleep, and then going through what that looks like, what safe sleep looks like, I think is super critical, and ideally modeling that in the hospital is important.